Okay, we are live streamed. I want to welcome all those who are listening and some who are participating in the first meeting of the Health Occupation Subcommittee of the Health Committee of the Maryland House of Delegates. We have 5 bills on our agenda for today, and we will begin with House Bill 7, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and music therapists authority to issue limited licenses to practice music therapy. Council, or is Delegate Gazone here? I don't see the full group, so I don't know. Are you with us, Delegate Gazone? Okay, Council, can you describe the bill, please?
This bill authorizes the State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists to issue a limited license to practice music therapy. The purpose of the limited license is to allow an individual to practice music therapy while completing the requirements for full licensure. A limited licensee must practice under the supervision of a fully licensed music therapist. A limited license is valid for 1 year, but it can be renewed for 1 additional year. And if the holder of a limited license fails to receive a full license within 2 years of receiving the limited license, then the individual must wait at least 1 year before reapplying for another limited license. There's no amendments, no opposition, and the board currently issues limited licenses also to audiologists, hearing aid dispensers, speech language pathologists, and speech language pathology assistants under similar conditions. So this just brings it as an option for music therapists.
Is there any discussion from members of the subcommittee? Is there a motion from a member of the subcommittee?
So moved.
It is moved. Is there a second from a member of the subcommittee?
Second.
Moved and seconded. Is there all those in favor of moving favorable on the bill as introduced, please say aye.
Aye.
Aye. I have 1 aye.
Aye.
2.
Aye.
I'm a 3, 4. Okay,
Aye.
that is 5. Is there anyone in opposition to the bill? Or anyone who wishes to offer an amendment? Hearing none, the bill will, well, no, that was on the motion to favorable motion. There being unanimous support for the favorable motion, the bill receives a favorable report. Okay, House Bill 42, Health Occupations State Board of Massage Therapy Examiners revisions. This is Delegate Bagnall's bill.
Back in 2022, chapters 705 and 706 phased out the registered massage practitioner credential. And under that bill, beginning November 1st, 2026, an individual would have to be licensed by the board to practice massage therapy in the state. This bill walks back that requirement and authorizes an individual registered as a massage therapy practitioner by the board to continue to practice under their registration beyond October 31st. So they can keep practicing as long as they have a registration, but they won't be offering any new registrations to anyone. The bill also alters the educational requirements for applicants for a license to practice massage therapy who graduated from an out-of-state program, clarifies which entities may accredit a massage therapy curriculum, repeals the requirement that the board follow hearing provisions to impose a specified administrative penalty, alters reinstatement provisions, and requires licensees or registered practitioners on inactive status to submit to a criminal history records check for reinstatement. There are no amendments. There was no opposition. I believe there's folks from the board here if there are questions as well on the bill.
Is there any discussion regarding this bill, House Bill 42? Is there a motion?
Hold on, put my hand up for discussion.
Sorry, I see it. Go ahead.
Thank you. So reading the bill on page 2, it says accredited existing language, accredited by an institution, accreditation agency recognized by, the U.S. Department of Education, new language, or another entity that accredits programs offering instruction in massage therapy. That seems very, very, very broad. What can you tell us about that?
Council,
I'm going to defer to someone from the board. They can
That's
speak to
fine.
that.
who from the board can speak to that? I can't see who else is on. Is
And
there
it's
someone from the
repeated on
board?
page, it's repeated on page 4, another entity that accredits programs offering instruction in massage therapy. I don't, it seems very, very broad. Like, are we not putting parameters on that? Are they, that is recognized by blah, blah, blah? It just, it seems very broad.
This is Sharon Oliver, the Executive Director for the Massage Therapy Board. We are using language that is consistent with the language that was used for in-state applicants. The law has that provision in for any individual who is educated in the state of Maryland. And we wanted to make sure that we were consistent with the language that is used for individuals who are educated by an institution outside of the state of Maryland.
But
So-
how do we know they hold to the same rigor and standards that Maryland holds to?
Repeat your question for me. I'm in a vacuum.
How would we know, like in the state of Maryland, we understand the rigor and standards that massage therapists who are trained here have to
Right.
meet? How do you know
Okay.
that an entity outside of the state of Maryland would hold to the same rigor and standards that Maryland uses? I'm concerned that we're disadvantaging Maryland trained massage therapists by allowing other people who may not have been trained with the same standards to, gain licensing and therefore work on patients that, they're not trained in the same way that Maryland massage therapists are trained.
And this is the very reason why the board proposed this regulation, this statute, to ensure that they are. We review the applications, we review the transcripts, we check with the appropriate state that accredited or approved the program that the participants graduated from. We also ensure that we have requirements that their curriculum must become to endorsed. And if that information is not made available to us, the board has the discretion to determine whether or not these individuals should be granted a license in the state.
Yeah, I see that later on page 5 of the bill. But again, I find that language, another entity that accredits programs offering instruction in massage therapy seems very broad. And then on page 6, there's language about allowing a former licensed massage therapist to renew, but if they forget to renew, they have up to 5 years to renew under the old standards. Is that what you're saying?
No, so individuals who allow their license to go into non-renewed or inactive status have 5 years in which to reinstate or reactivate. If they go beyond the 5-year marker, the way the law is set up, they must reapply for a license as if they never had one before. And because the board is no longer authorized to issue an initial registration, if someone has a registration and they have been in non-renewed status beyond the 5-year, they must come back as a new applicant and they must qualify as a licensed massage therapist.
Yes, that's how I read it as well, but why did you pick 5 years?
That's the standard across most of the health occupations boards, that if you are out for at least 5 years, you must demonstrate the credentials necessary and the qualifications to qualify for licensure.
Okay. Thank you. I still remain concerned about that very broad language. Thank you.
Do
You're
you wish
welcome.
to offer an amendment or hold the bill until you can prepare an amendment?
No,
Delegate?
no, thank you for that offer. No, I don't. I mean, I guess what she's saying is when you go on to the next page, the board has an opportunity for someone who graduated from out-of-state program that does not meet that they are going to be assessing them individually. So, you know, again, they're working on it's patient care. I'm concerned, but not concerned enough to, I don't know what amendment would fix it. So thank you.
Well, we're asking, my sense would be that to trust in the board that it is evaluating the out-of-state provider sufficiently to make sure that people who would be practicing in Maryland with an out-of-state license will not be doing a disservice to Maryland patients. Okay.
And delegate, that is the very reason that this was introduced, because there were no provisions there to ensure that the board had the authority to vet these individuals thoroughly to ensure that we are protecting the public and that they are adhering to the same standards as the Maryland graduates.
Okay. Thank you, Madam Chair.
And if I
You're
may,
welcome.
this is Stephen Conti, Chair of the Massage Board. There's a wide array of initial education hours across the board. So some states have 500, some have 1,000. So we recently, in the last 2-3 years, we've raised our standard to 750 to have higher education, higher credentialing, more practice, more experience. So the concern somewhat is someone's coming in from another state without the same level of training and education. How do we, there's no like for like vis-a-vis a compact. So how do we evaluate and vet those folks where they're not coming in and doing any harm?
Okay. Is there a motion for a favorable on the bill?
Delegate Riley has her hand up as well.
I'm sorry, I can't see it. Delegate Riley.
Yes, thank you, Mr. Chair. I think the board members did an excellent job in explaining some of my questions already. But just to Delegate Shalega's comment, so I know that, I believe it was Sharon from the board had said that they're taking this broad language that Delegate Shalega was talking about from other boards. Can you tell us where this is actually used currently?
No, it's not with other boards. It relates to Maryland. The language is there for the Maryland applicants, where we wanted by an organization approved by the U.S. Department of Education and or a similar accrediting body in the event that the U.S. Department of Education is no longer in existence. We want to make sure that we plan for the future, and if accrediting bodies change, the board has the latitude to identify another accrediting body.
Okay, you explained it, I think, quite well, you know, why you chose this language, but thank you very
Yes.
much.
You're welcome.
Okay. Seeing no other hands, now that I have access to everybody's hand, electronic hand, is there a motion for a favorable report?
Move favorable.
So
Second.
moved. Is there a seconded? All those in favor, please say aye.
Aye. Aye.
Anyone opposed? Okay, the bill moves forward unamended with a favorable. House Bill 274 State Board of Environmental Health Specialists, sunset extension. This is a departmental bill. Council,
This departmental bill extends the termination date of the State Board of Environmental Health Specialists by 5 years from July 1st, 2027 to July 1st, 2032, subject to the evaluation and reestablishment provisions of the Maryland Program Evaluation Act. There are no amendments, no opposition.
is there any discussion? I see no hands. Yes, now I do. Delegate Szeliga.
Thank you. I see that there's some favorable testimony on the bill. And just tell us what the environmental health specialist, what this licensing is, just if you could give us a little more information about that.
Okay, I'm assuming that's directed to me. I'm
Anybody.
the executive. Okay, I'm the executive director of environmental health specialists. Yeah, it's just, I mean, I just started in this position last summer, but this is a standard thing every 5 years. It comes up for sunset. Environmental health specialists, the people that do restaurant inspections, public swimming pools, bathing beaches, and all that. Rabies. There's lots of other things they do. They issue well and septic permits. The people we license go out and do all that work, and so we're the ones that issue that license here in the state of Maryland.
Okay, thank you.
Is there any other discussion on House Bill 274? Chair seeing none, is there a motion for a favorable?
Move favorably.
So moved. Is there a second?
Second.
Seconded. All those in favor, say aye.
Aye. Aye.
Anyone opposed? Okay, that moves favorable. Let's skip over 377 because that's going to take a while, and do 380 and then go back to 377. House Bill 380, Council.
This
State
bill-
Board of Examiners, I'm sorry, State Board of Examiners and Optometry, examination requirements and time period for inactive status. Council.
This bill clarifies examination requirements for licensure and reinstatement under the State Board of Examiners and Optometry by specifying that an applicant for licensure or reinstatement must pass all sections of each part of an examination, and the board must determine the passing scores for all sections of each part of an examination. The board's prohibited from placing a licensee on inactive status for more than 6 consecutive years. The bill also repeals the requirement that the board give examinations to applicants not more than once every 6 months and notify applicants of the time and place of the examination, and that an applicant may pay a reexamination fee to retake the licensure exam. There are no amendments. There was no opposition.
Is there discussion? Chair seeing no rate. Yep. Delegate Riley.
Thank you, Mr. Chair. I believe this is the bill during the hearing. I believe it was Delegate Austin who asked to, get the opinion. I believe it was Delegate Miller's, since she is an optometrist, to see what she thought about that. I know she did go to her office. So I see Delegate Austin there. Thank you.
Mr. Chair, can I respond?
Delegate Austin, absolutely.
Thank you. Yes, they did have an opportunity to speak with Delegate Miller. Delegate Miller is fine with the bill.
Okay. Thank you.
Thank you.
Appreciate your inquiring for us. Is there a motion for a favorable?
Move
moved.
favorably.
Second.
Move. Is there any opposition to the favorable? The bill receiving a favorable, unanimous favorable. It is a favorable report. We will now go back to House Bill 377, physician assistants, parity with other healthcare practitioners. Council.
This bill authorizes a physician assistant to perform numerous additional duties as specified, requires that a health maintenance organization quality of care standard include a requirement that each HMO member has an opportunity to select a PA as primary care provider, adds a PA to this member to the statewide advisory commission on immunizations, and excludes a PA from the definition of healthcare practitioner with respect to healthcare staffing agencies. I circulated a couple sets of amendments for this bill. One set of amendments came from MedChi. These were discussed orally at the hearing, but we didn't have them in writing at that point. The MedChi amendments for voluntary admissions specifies that a PA have advanced duties in psychiatry or be making the decision in an exempt facility. The theory being that the facility then would be the one determining whether or not the PA has the right to make that decision. Removes PAs from provisions relating to involuntary admissions. Removes a provision allowing a patient in an HMO to select the PA as their primary care provider. I also circulated, amendments from the sponsor, Delegate Johnson. There were two provisions related in these. One relates to pregnant incarcerated individuals being admitted to an infirmary and adds nurse practitioner, certified nurse midwife, licensed certified midwives to that list. And I inadvertently struck PAs, but I think they want to keep PAs in there as well in that list. And then in the provision that I just described relating to the HMO member ability to select their primary care provider also adds to that list a certified nurse midwife and a licensed certified midwife. There were also amendments submitted in testimony from the audiologists that would like audiologists to also be able to sign certificates of sick leave. And several other sets of amendments also suggested adding mental health training with regard to the admissions from PAs. So,
I mean, requiring mental
That's
health
sort of-
training.
yes.
Right.
That's sort of the universe of amendments that have been offered on the bill.
Mhm. Well, let's have someone speak who's in favor of the bill
I
regarding
believe the
amendments.
sponsor is here.
Sponsor.
Thank you, Mr. Chair. Yeah, those, as you see, we've got a lot of amendments on those, on the bill. I would be okay with the amendments that have been offered.
All
And
amendments?
You're correct, Lindsay, the physical, the physician's assistants, yeah, was supposed to be included in that last amendment.
You're referencing your sponsor amendments.
Correct, yes.
Okay, those sponsor amendments again were the addition of nurse practitioner, certified nurse midwife, licensed certified midwife to the list of folks who can do an admission of a pregnant incarcerated individual to infirmary, and addition of certified nurse midwife and licensed certified midwife for the ability for a member of an HMO to select a primary care provider.
Correct.
Is there discussion about those amendments, the sponsor's amendments? Hearing none, seeing none, the sponsor amendments will be considered adopted to the bill. Okay, who else? Is there another supporter of the bill who wishes to speak to other amendments?
Delegate Riley's got her hand up as well.
Delegate Riley and then Robin Elliott.
All right, sorry, Mr. Chair, I didn't know.
And
So
those-
I'm assuming that amendment was finished with discussion. So I was wondering if there was anyone here that could discuss the other amendment. I believe it was from MedChi. Do we have anyone to speak of that one?
Mr. Wise is here.
Okay, I'd like to hear what he has to say.
We
That's
can
all
hear
right.
from him. Steve?
Thank you, Delegate Riley. So Lindsay did a excellent job outlining our amendments, and they really on the involuntary admission, which I'm going to let Dr. Davis, if that's okay, Mr. Chairman, discuss that one. If you
Sure.
choose to call on him. On the voluntary admission, if you look at who is currently allowed to do voluntary admissions, that includes right now 2 licensed physicians, 1 physician, 1 psychologist, 1 physician, 1 psychiatric nurse practitioner, and the list goes on. But the point is, those are all folks that have some additional mental health training. And what we're saying with the amendment on the voluntary admission is we want to make sure that the PA similarly has that additional mental health training, which not all of them do at a base level. And on the HMO amendment, being able to designate a PA as a primary care provider, as you probably know, Delegate Riley, PAs and physicians have to have a collaborative agreement. And the agreement, the PA can't practice without such an agreement. If a PA is able to be selected individually, but they, let's say, leave their physician, we think that's going to create some patient confusion, and in addition, raise some questions about who's billing in that environment. I recognize that under Medicare and Medicaid, the PA can be designated, but I think private insurance may raise some additional questions that frankly, we're still trying to figure out the answers to. So the voluntary admission I covered, the HMO I covered, and I think if you're so willing, Delegate Rosenberg, I'd like Dr. Davis to cover the involuntary admission.
Certainly. Are there any questions from members of the subcommittee that you feel could be best answered by Mr. Wise before we go to Delegate Dr. Davis? Okay, Dr. Davis, please.
Hi, thank you. So the issue with the involuntary certificates is that they're being evaluated typically in an emergency room setting to be hospitalized against their will. Right now, it's two physicians have to make independent evaluations and make a determination, or a physician and another health professional. Right now, the current list of 4 health professionals are all at least master's trained licensed mental health professionals. Psychiatric nurse practitioner, for example, is one of them. It's not any nurse practitioner. It's only nurse practitioners who've got that extra master's level certification in mental health. Physician assistant just does not have that additional education and training. And we believe that if you're going to put somebody against their will into a psychiatric hospital, let's make sure that if 2 physicians can't evaluate them, at least one of those individuals has a mental health professional licensure. That's the way it is right now. If you add PAs, it would dramatically change who can be that second evaluator.
But you would still have one person who has that mental health proficiency.
Not if it's just a physician and a PA. Doesn't require a psychiatrist. It's a physician. Typically it's the emergency room physician who's depending on their mental health expertise of that second person.
Okay. Any questions for Dr. Davis from members of the subcommittee? The chair will recognize Robin Elliott.
So good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Academy of Physician Assistants. The bill that you have in front of you, because I know there's a lot of discussion about a few sections, contains 22 sections. And at core, what we were trying to do is instead of asking for you all to consider 22 bills is to combine everything in one. And we really appreciate Delegate Johnson and this subcommittee to really consider the way of doing that. There are a lot of sections of law that have not been updated for a long time. And so at the core, what we're doing is looking at where PAs can practice alongside other advanced practice clinicians, recognizing that this General Assembly really redid how PAs were licensed with the collaborative practice legislation in 2024. That was Delegate Kerr's. So I'm going to speak to the issues raised. I will sort of first focus on the primary care question, because I think in many ways that's the most straightforward. So this part of the law has to do with the Maryland Department of Health and when they regulate HMOs, which are regulated differently than other insurers, that they can consider in terms of primary care other practitioners, and missing from that list are PAs, CNMs, and licensed certified midwives, which you all added in that amendment a few moments ago. Really, if you look at Medicaid for a long time has recognized these other advanced practice clinicians as primary care clinicians. We also had a big change in Medicare in 2022. We really believe that there should be equitable access to primary care providers, no matter what kind of insurance that you have. And so with that, we would really make a strong case for the General Assembly to continue its work in recognizing and expanding access to primary care. Next, I'll speak to the other two voluntary admissions, just because I think that's a little bit more straightforward. There are two sections. One has to do with a parent or a guardian voluntarily admitting a minor to either a state facility or a RICA. And in that admission, what they are doing isn't changing at all. And I'm looking at the Maryland Department of Health's form. The person who is the signatory is affirming that the individual has a mental disorder, that they are susceptible to care and treatment, and that the applicant, that would be the parent, understands the nature of the request of the admission. PAs, as we have some PAs on here, are do have training in psychiatric and behavioral health issues. The amendment in front of you is not actually aligning with the collaborative practice law that you all passed in 2024, which also recognizes PAs who have advanced experience and much experience are exempt from advanced duties. And then the framework for the consideration of also voluntary admission of disabled people is very, very similar. We would just note that these are voluntary admissions. We do not want anyone to have to wait longer than they have to. On involuntary admissions, I think that is probably the more complicated piece. We do have a couple PAs on today who can speak to the data. You do have data in your packet in front of you, which shows a remarkable difference between hospitals that have two signatories on staff. So a physician and a physician, a physician and a psychiatric nurse practitioner, and hospitals where that second signatory is not available. We show that it's nearly twice the waiting time for the admission. The bill in front of you does not change the standard for involuntary admissions. It recognizes that we have a shortage of practitioners, and we have practitioners who are qualified to do this. Hospitals have to make sure they're qualified. Those qualified individuals are in our emergency departments now, and they can make the difference in getting people into care faster so they do not have to linger in the emergency department. I do have a couple PAs here who can answer some more specific questions on the data, and I do recognize at least one hospital colleague who is here as well. And I'm happy to answer any questions.
Are there questions from the members of Robin Elliott? Okay, seeing none. Michael Tran from the department.
Good afternoon, everyone. This is Michael Chan with the Maryland Board of Physicians. This is more of just an update. I believe at the hearing, Delegate Colson asked a question if the board had discussed the topic of voluntary, involuntary admissions. I did bring that back to the board and we discussed it, and the board is okay with the current language, and that is due to all psychiatric duties for physician assistants have been deemed as an advanced duty. So therefore, we believe that there is some type of guardrail in place to kind of oversee the practice of the PA in the situation.
Delegate Cullison. Can't hear you. You're muted.
Sorry about that, Mr. Chair. Thank you. I'm going to harken back to my educator days for just a moment, Mr. Tran, and make sure that I heard you say what I think you said, which was the Board of Physicians is comfortable that all patient safety requirements are met by the bill as presented.
I will say that yes, the way that the bill is written, we believe that it falls under like the supervising guardrails that we already have in place within the bill that was passed in 2024. We want to maintain on our end that we're reviewing all advanced duties, and all psychiatric duties are advanced duties. And if a PA falls under one of those exemptions are there because they have already qualified for a alternative method, whether that be through the hospital who does their own credentialing process, or they've already been approved by the board. So either way, there has been some overview on the PA being able to do this duty.
Okay, so I just want to emphasize there has been some oversight in these situations. So thank you very much, Mr. Tran. I appreciate it. And
Thank you,
Mr. Chair,
Delegate.
thank you.
Thank you, Madam Vice Chair. Delegate Riley.
Thank you, Mr. Chair. Yeah, actually, I was going to ask a similar question to Mr. Tran, but I saw that Mr. Wise is up there now. So I would just like the definition. I mean, Mr. Tran said advanced duty. So does advanced duty mean that they actually have licensure or certification in psychiatric training? It sounds like what he just said does. So I would like to give Mr. Wise the opportunity to explain, how you think that is good enough or not good enough, or what that training is. And then if Mr. Tran would like to follow up on that as well, it'd be great. Thank you.
All right, to respond, Mr. Chairman.
Certainly.
Okay. I'll start with a minute of background and then I'll answer your question. Under the way the PA law has worked for many years, if you are performing advanced duties in a hospital, for example, you're exempt from getting those advanced duties approved by the board. If you are not in an exempt facility, you have to go to the board and demonstrate competency, basically along with the physician with whom you work. Now, on the voluntary admission, our amendments say that if you're in the exempt facility, the hospital, nothing's changing. You're still exempt from having to demonstrate those advanced duties because we depend on the hospital to make sure they're qualified. What our amendment gets to is those rare instances where the person is being certified by somebody that's not covered by the exemption, right? That they might be outside the hospital. So all we're saying is really what the law already says, which is they need to have those advanced duties in that scenario. Separate from that, on the involuntary, we respectfully disagree with the board. And our position is that, as Dr. Davis explained, by adding a PA here to involuntary admission, taking away somebody's liberty, the second person should continue to have some mental health training. And by making this change, you're losing that. So in the situation where you have a physician and a PA who doesn't even have advanced duties, you've lost that. So we strongly disagree with the board on whether that's truly preserving patient safety.
Are there questions for Mr. Wise? Delegate Cullison.
Thank you, Mr. Chair. So Steve, I hear you. But I also hear that people in this very vulnerable, very difficult and challenging situation could wait as much as 6 hours to get help because there are not enough people who can be that second signatory in these situations. And so are we really doing them good service to have them wait twice as long as they might if a physician's assistant were with the advanced practice certification or requirements to be the second signatory?
I would like Dr. Davis to respond to that, but I'd answer the question with a question. Are you really doing that patient a service by involuntarily admitting them when they haven't been seen by somebody with mental health expertise?
May I respond? Mr.
Certainly.
Chair? We trust our physicians, right? It's very clear that the physician is the first person to be trusted here, and that what we're asking is that the second possibility be a physician assistant. So if we are trusting physicians who do not have mental health training to take away someone's liberty, and again, I think these are pretty extreme situations where I suspect the hospitals are doing everything they can to support these individuals. So I would say we have the faith in the physician that they're making the right decision. And if you say, but that physician may not have mental health certification or training, then I would say we need to change the law to say that only physicians with mental health training can make these recommendations. So, I mean, I think what we're trying to do is help these folks get help as fast as they can. And with all the guardrails, the current processes in place, nothing as Robin said, nothing about the process is changing. None of the requirements and guardrails and guidelines around the process are changing. Simply adding the ability for another healthcare practitioner, licensed healthcare practitioner, to sign on. So I will stop now, Mr. Chair. Thank you.
Can anyone in the Zoom speak to the staffing question or the likelihood that there is a physician trained in mental health in the emergency room?
I think Dr. Davis can best speak to that.
Certainly, Dr. Davis.
Yeah, I can speak to that. There is sometimes, but certainly not always, a psychiatrist in the emergency room. Many emergency rooms do have psychiatrists on call or on staff that can evaluate, but we actually don't trust just one physician to take away somebody's liberty, which is why there's a requirement that we have 2 physicians. In the instance where there's just one physician, we want to, right now, the law is that a trained mental health licensed professional is doing that second evaluation. If you add a PA, then we will no longer have that second individual be a licensed, trained mental health professional. And if we add the PA, then you might as well also add nurse practitioners that are family medicine nurse practitioners and all the other nurse practitioners that exist. There's only one of them that has the mental health certification. The others do not. And so this would be a change, a very significant change. And of course, your constituents are probably not going to be pleased if they know that they're going to be put in for up to 10 days in a psychiatric unit without ever having an evaluation by 2 physicians or a mental health certified professional.
Delegate Zaliga.
Thank you. So I guess to Steve Wise, it sounds like MedChi may be amicable to the voluntary commitment part, but for the non-voluntary, that's where when it comes to the training of the PA, is that correct?
Yeah, I mean, I would characterize our amendment on the voluntary as sort of clarifying what the law already is. But on involuntary, I think we just have a fundamental disagreement.
Okay, and in the non-voluntary, if I'm reading the bill right, it says psychiatric nurse practitioner. So assuming if the second signature is that right?
That's one of the options currently for involuntary admission, a physician and a psychiatric nurse practitioner. So not just any nurse practitioner.
Okay, would there be a way to put similar language for the PA? I mean, do they have a psychiatric PA, or is there?
What? Yeah,
because
the equivalent of that, if you will, would be somebody who's had advanced psychiatric duties approved by the board, but you know, in the hospital, that determination is left to the hospital as to whether they've got those credentials or not, and those may vary by hospital. Again, I think we just have a fundamental disagreement over whether this should be permitted at all by a PA on the involuntary front.
Okay, thank you.
Delegate Lopez.
Thank you, Mr. Chair. I have kind of a two-part question. Can someone refresh my memory on what the standards of admission are for voluntary? Just foundational. And then the second part is that I would love to hear the advocates from the behavioral health space chime in right now. I don't think we've really heard too much from them.
Valid point. Is there someone who can speak from the mental health advocacy standpoint? Robin Elliott.
I think I may be able to address both questions. So I have in front of me the form from the Department of Health on voluntary admissions, and the three boxes. One is that the individual has a mental disorder, which I think PAs can ascertain, that the mental order is susceptible to care or treatment. I know it's kind of strange language, but I think it means it can be helped. And then that the applicant, who is, in the case of the minor, it would be the parents, understand the nature of the request for the admission. And of course, if you're a person who's seeking voluntary admission for yourself and you're an adult, that you understand that. I don't see the behavioral health groups on the on our Zoom box, but there are letters of support from the Baltimore Behavioral Health System, the NAMI, and the Maryland Rural Health Association. All three cite some similar perspective that this is a way that we can make sure that people on the involuntary side, as well as the voluntary side, get care faster, and that nothing in the bill purports to change the standards for either sets of admissions at all. So, and I do have, I think her hand is raised up just to let everyone know, physician assistant who does a lot of work in the emergency departments, who can kind of speak to some of the other questions if the committee would like.
Kelly Schultz. Kelly Schutz, sorry.
That's good. Yeah, thanks. No, just to speak to, psychiatric availability in our hospitals. Many of our hospitals, have very limited coverage when it comes to actual psychiatry coming in-house. We do have some capacity for telehealth with our licensed clinical social workers, which does occur. And a lot of this, occurs in conjunction with them. It was said that emergency physicians, if you have them, that they're kind of not considered an expertise in psychiatric care, and we rely on someone else with psychiatry. Our emergency medicine colleagues, the physician colleagues, they are calling our licensed clinical social workers, with this request. They've already, said this patient needs an involuntary, admission or transfer. These are patients that we are taking care of, and we are going to the physician and letting them know that this is a patient that either needs voluntary. We are, taking care of the patient. We are taking care of their medical needs, their psychiatric needs, and taking care of them up unto the point of signatures. And we are going there and requesting that. Like I think Delegate Hollison said, there are 6 to 7 hour wait times for our sites. And this directly correlates with times from the patient's arrival to when we decide to get these patients admitted. It's not something as simple as looking at when were the signatures signed, because that occurs at sign out right before the new oncoming physician arrives. So this is metrics, this is data that we have, that really shows that there is a delay specifically for our hospitals that do not have the inpatient, the psychiatrist available in-house to be able to come. But despite that, we work as a team. There's lots of people involved with this. To say that with a emergency room physician and an emergency medicine PA to not have had any kind of either psychiatric expertise or ability to deem these patients that they need the help that they need, I think is a stretch. Thank you.
Delegate Alston. Delegate Tavares.
Yes. Hello. Can you hear me? I'm sorry. I didn't realize I was still
Delegate
muted.
Alston.
I was just
quicker on the
talking.
trigger than you were. Go ahead.
I was just saying the discussion on the bill has been really good, and it's leaving me with more questions than answers right now. And I was just curious, are we planning to vote this today? Because if so, I have a lot of unreadiness.
Well, it's important for us to know about your unreadiness.
Okay, so that's what I wanted to say. I would like some time to continue reading. I didn't know if you were planning to hold it or not, but I didn't want to cut off the discussion because it's lots of good information, but I'm not ready to vote. That was
I
all I
appreciate
wanted to
that.
say.
No,
Thank
that's
you.
valuable, very valuable. I was going to suggest, or at least put on the table, which is more neutral, whether a sunset provision is of value in terms of moving the bill forward. And if that should be part of a 2-year sunset, so that we would have some evidence of whether there were instances where people were wrongly admitted. Delegate Tavares. You are recognized. Delegate Tavares.
Thank you. Well, I've been listening to the conversation. As someone who's had to live this experience with people close to me, where we've had to wait and so on, the question I have is, why is there not a comprehensive standard across the board on credentialing these individuals so that we can all be on the same page in terms of assessing the behavioral health needs of individuals within the emergency room, particularly within um, um, for whoever it is, whether it's the nurse practitioner, we already know we have licensed clinical social workers that are can do that as nurse practitioners. But if we're going to add the physician's assistant, why is there not a concerted effort to have the same standard across the board? The other issue is how this standard for admission, particularly when it's involuntary, to me is equally as important, not just the voluntary, but the involuntary, right? Where there is or at least a requirement for outpatient treatment. Because as in considering, let's say like the AOT bill, we had the mother of someone in the neighborhood has paranoid schizophrenia, went to the court, got the child evaluated. Well, not a child, he's a full man, got this kid evaluated. He's already racking up criminal charges and he doesn't want to get the assistance. So where does that line start and where does it stop? Where the mother has to live with this person and she's afraid for her life and that of her daughter. And she's got no choice to protect herself in this situation because this individual doesn't want to get the assistance. Because according to him, he doesn't feel he needs it, right? So to me, these are very real questions. So I do think that it would be better to have more rather than less people qualified in the hospital. But there has to be a standard of care across the board that's equivalent for us to say, okay, these individuals are credentialed to do this work. I'll leave that there. And that to me, it seems like it's absent.
Thank you, Delegate Tavares. Very personal. Delegate Zaliga.
Thank you, Chair Rosenberg. As we're discussing this, and I would agree with Tiffany that I'm not ready to vote this either, but when we come back to revisit it, I also would like some questions answered about page 3 of the bill at the bottom going into page 4, which is life-ending care. So, it's the cost of incapacity, a healthcare provider may not withhold or withdraw life-sustaining procedures on the basis of an advance directive when no agent has been appointed. So, I'd like a little more information about, that's obviously end of life care, determining whether to stop life-sustaining treatments on a person, and maybe Robin or somebody could talk about that. I know it says physicians, attending physician, and a second physician or a nurse practitioner adding physician's assistant. have certified that the patient is in terminal condition, blah, blah. The rest is existing.
Thank you, Delegate. I mean, I think the chair recognizes that there is an unreadiness to move forward with this bill. I would ask the affected parties to keep this discussion going between now and next Tuesday. And if the sponsor wishes to join those discussions, he should certainly be made aware of them.
Thank you, Mr. Chair.
Okay. That, I believe, concludes our business for today. There is a 1 o'clock budget briefing before the full committee, followed by bill hearings. So I appreciate everyone's contribution today, and we are now adjourned. Thank you.